morning, one and all. Can I start? Good morning, one and all. I'm Dr. Sandhya DHARWADKAR from Mysore Medical College. As we all know,
Ma'am, can you be a little louder, please? I think the voice is...
दूसरा वाला भी चालू करो.
My time is going. Ocular tuberculosis includes the entire spectrum of clinical presentations caused by the Mycobacterium tubercle bacilli, either by direct invasion of the eye or as a immune-mediated inflammation in response to its antigens. The intraocular disease is very difficult to get confirmation directly, and hence we term it as presumed. Since the first proven case in 1883, where the bacilli was identified, till the present era, our understanding of this disease has evolved tremendously. We have better guidelines, we have better treatment modalities and diagnostic tests. Keeping this in mind, we took up this study, which was a retrospective observational case series at a single center, during which we had 10 consecutive cases which we identified and followed up for a period of a year. We had patients from 20 to 45 years of age with equal gender predisposition and equal laterality. The vision acuity presented from about 6/12 to PL positive cases. The anatomical involvement in our patients were about 40% presenting with panuveitis, another 40% having choroidal granulomas, while just one case of occlusive vasculitis and multifocal choroiditis. A few of the cases I'll show. A single choroidal granuloma presenting in a 22-year-old male, the OCT showing the typical choroidal elevation with subfoveal fluid, treated with ATT alone and good resolution to 6/6 in a month or two. This is another granuloma, but lying along the optic nerve, presenting with PL positive vision. This patient was Manto positive, gave history of contact, and was treated with IVMP along with the ATT. She continued only the ATT for about 6 months. The vision improved to 6/24. This was a case of occlusive vasculitis, unilateral involvement with pipe stem sheathing and multiple hemorrhages, multifocal involvement, who was Manto positive. Other cases with anterior broad-based synechiae showing anteruveitis. A 35-year-old female having bilateral panuveitis-like picture. She was Manto negative, quantiferon TB negative, but the HRCT picked up features of old COX. She was treated with both oral steroids first along with ATT, but did not tolerate the oral steroids. Hence, she was treated with injection of posterior subtenon and Skinacort. Over a period of time, with immunosuppressives were continued, and she improved to 6/12 with good resolution after 3 months. This was the most difficult case that we had. A 27-year-old female with one eye choroidal granuloma, resolved very well after 6 months of ATT and oral steroids. For 6 months, she was fine, and then she developed a multifocal relapse. Because of this, she was again given ATT along with immunosuppressive therapy. Still, over a period of time, she still worsened and had severe vitritis, which had to be treated with a vitrectomy. After that, the immunosuppressive therapy was continued and 9 months of ATT was given. We suspected it to be a multi-drug resistant tuberculosis. She stabilized after a period of 1.5 to 2 years, and this was her final picture with a 6/60 vision. The outcomes in our patients' vision improved in most of the cases from 6/6 to 6/60, and the disease activity stabilized with multimodal treatment. The residual vision loss was noted to be either because of cataract or a scar at the macula. The recurrence was noted in only one of the cases. All the tuberculoma patients resolved with ATT alone. To discuss, India still has a very high endemicity of tuberculosis. The risk factors further increase because of the population, crowded, unhygienic conditions, either the improper use of ATT causing drug resistance, and the emergence of HIV positive cases. The varied manifestations allow for the delay in the diagnosis sometimes, and the management also is not as structured. But nowadays, thanks to the guidelines given by the COTS study and the COTS calculator, which is available online, it has allowed for much better treatment outcomes. So for our patients, we have a checklist where we have a history of contact with the tuberculosis case. We rule out mimickers, especially ocular syphilis, sarcoidosis, and sometimes viral cases. The diagnostic test, we try to include all 3 of them. We take a pulmonology opinion if we have features of pulmonary positivity on HRCT, and then the treatment is tailored based on the COTS guidelines. To conclude, presumed intraocular tuberculosis is like a parody of maladies with every presentation possible, and the outcomes can be improved with timely diagnosis, early and appropriate treatment, especially the immunological therapy. Thank you.
Very nice. Yeah.
Thank you, sir.
Yeah. Thank
I'll
you.
have a few questions. I think it's a very gray zone when we talk about the discussions regarding the diagnosis for intraocular tuberculosis. If there is a tuberculoma, it's fine because it's a straightforward case, you can start with treatment. But when we talk about the diagnostics, do you believe only Montux, what should be the cutoff value for you? And when you talk about the 3 diagnostics to be taken together, what is your take that what should be the, the cutoff value for us to diagnose that?
Yeah, thank you. We try to get all the 3 tests for each of the patients where we are suspecting ocular tuberculosis and include it as a part of the COTS calculator, wherein we have the MAN2, the quantiferon TB gold and the HRCT. Very rarely we have patients who cannot afford and we avoid the quantiferon TB gold, where the patient has a typical tuberculosis feature or has a recurrence. We try to start off with anti-tubercular treatment as well, along with the oral steroids or immunosuppressives.
If
So
you
the
have
COTS
any
calculator guidelines accordingly, we usually use a median 4 or an interquartile range of 3. We start off with the ATT
If
cover.
you come across any case where you don't have any tuberculoma seen on the fundus evaluation and all the 3 tests they come out to be negative, how would you take up such case? Would you start the treatment or how will you take?
If the tests are negative and there is no posterior involvement, then we don't start the
The
ATT.
patient has vasculitis, but you don't see a typical tuberculoma.
Vasculitis, I would not suggest just ATT only for vasculitis. If it's an idiopathic vasculitis is much more common. We don't start if we don't have any other tests negative or positive.
Do you believe in starting a trial of ATT if you have a positive history
No.
of contact in the patient?
Positive history of contact has to be a very much high risk, as in a family member wherein has had pulmonary tuberculosis and a positive sputum. We try take a pulmonology opinion, a bronchoalveolar lavage if required, along with an HRCT test. So other than that, we don't start ATT. We give the options to the patient, but we try to avoid if it is not showing a positivity on either of them, MAN2 at least 10 millimeters.
Maybe I believe if the patient is not responding to treatment as is required as we think it should be, and we have a strong positive Montus because it's very dicey, it may go
Agree.
Anywhere
way, yeah,
in
either way.
Indian subcontinent. So I usually prefer to have a trial because it being quite a safe. So usually they respond tremendously, very nicely if they are suffering from the tuberculosis.
Actually, the microbiology student whom I showed, the difficult case, who presented with a granuloma, she was MAN2's negative, quantiferon TB gold negative, HRCT, MRI brain, ultrasound abdomen. We couldn't
Nowhere.
find anything. I wanted to start ATT because I know the typical picture.
Yeah.
And still I gave her ATT
Yes,
along with oral
absolutely.
steroids. It recovered completely in 6 months.
Absolutely.
Another
So I think
6 months
trial
later.
won't harm the
Yeah,
patient
but
for a
that is
month.
considered like a typical tuberculosis in the eye. So there are some features like these which can be started on ATT based on the clinical picture alone. But I think anteriouveitis and vasculitis are something which we need to take it with a pinch of salt.
Absolutely.
And
Thank
Dr.
you.
Sandhya, one question. Very nice cases, everything good. I differ in one aspect. You said that I gave ATT for 6 months. I think we give ATT for 12 to 15 months. 6
Okay.
months, they're bound to recur, like you saw recurrence in
One
your
of them,
case.
yes.
So,
We still follow a period of 6 months for most of them, ma'am. And sadly, we have patients presenting with the ethambutol toxicity at the end of
Yeah.
4 months because of the high dose
no, but
nowadays.
for our ophthalmic patients, we follow the same regime. After 2 months, I think we stop
Another 4
ethambutol.
months. Huh.
We do stop in our patients. For
Okay,
ophthalmic,
okay.
the guidelines, they've changed. They
Yes,
say ophthalmic involvement will just stop ethambutol.
Okay, okay.
So then it
Fine.
works.
That's a
Just
nice
wanted to ask you
point for me.
Same as ma'am's.
Okay.
At least it should be for 12 to 15 months. Otherwise, the recurrence is bound to occur and we are creating MDD patients again.
Yes, sir, that would be
Now
one
there
of
is
the
a new
major.
regimen which abolishes ethambutol out of it and a new drug is added to the new
Linezolid?
They do it for
Linezolid? Okay.
But even linezolid has ocular toxicity if you've seen
Can
it
have
causes
optic
optic neuropathy.
neuropathy. Yes.
So I've
Optic
had a lot of patients with linezolid toxicity.
They also have.
Ethambutol has very good action against the tubercle
Yeah.
bacilli is
No,
what they
but
say.
we've
So
had
at least the initial 2
So
months.
many blind.
No,
First 2 months.
You know,
yeah.
the problem is the FDC. Because they are
Okay.
just giving the drug as per the FDC, which is freely available.
Which is
as per the
available in
weight.
dots. Yes.
You know, so as per the weight, if the patient little heavy, then the dose goes beyond the toxic
goes
dose.
much beyond the
Much
toxicity.
beyond.
Yes, sir, exactly.
Last question I had, sorry to bother you. What about the role of intravitreal avastin in these patients with, recalcitrant
Yes.
granulomas,
So this female did have intravitreal anti-VEGF as well.
Okay,
But
that's what I wanted to know.
over a period of time, it just was a very temporary treatment. She didn't respond that well as expected. So vitrectomy did stabilize the disease completely.
Okay.
It removed the load, I think,
Right.
of the bacilli and allowed for a very good control.
Nice.
Yes, sir.
Thank you.
Thank you. We have not tried a vitreous biopsy yet, but the vitrectomy case, that vitreous sample was sent.
So it was positive or-
No, it was not.
Okay.
We couldn't get a positivity at all. Thank you.
Thank you so much. Thank you. Yeah. So I think good discussion.